Hello everyone, today's session is jejunum to sigmoid colon. In the previous video, I covered the brief embryology and the gross anatomy, and in this video, blood supply, lymphatic drainage, nerve innervation, clinical points and some essay and MCQ questions will be explained. Let's look about the artery supply. From the abdominal aorta, superior mesenteric artery and inferior mesenteric artery arise. From the superior mesenteric artery, the jejunal branch, ileal branch, ileocholic artery, right cholic artery and the middle cholic artery arise. Arteries of the jejunum and ileum lies in the mesentery of the jejunum and ileum. There are some differences between the artery supply. For the jejunum, the arterial arcades are single for the upper jejunum and double for the lower jejunum, while ileum has 3 to 5 arterial arcades. The straight arteries are long in jejunum, short in ileum. So, the window between the straight arteries are narrow and high in the jejunum, wide and short in the ileum. Because of the less mesenteric fat in jejunum, the arterial arcades are more visible in jejunum, but ileum has more fat in the mesentery. So, the arterial arcades of the ileum is less visible. This is the ileocholic artery, right cholic artery and the middle cholic artery. Ileocholic artery divides into superior branch and the inferior branch. This inferior branch gives off 4 branches: an ileal branch, appendicular artery, posterior cecal artery and the anterior cecal artery. The right cholic artery divides into ascending branch and a descending branch. This descending branch and the superior branch from the ileocholic artery are anastomosing here. This is the middle cholic artery which divides into right branch and the left branch. This right branch and the ascending branch of right cholic artery anastomose here. Now, the inferior mesenteric artery gives off left cholic artery and sigmoidal arteries. The rest of the inferior mesenteric artery continues as superior rectal artery. The left cholic artery divides into ascending branch and descending branch. The ascending branch will be anastomosing with the left branch of middle cholic artery. The sigmoidal artery gives off 2 or 4 branches. The higher branch will be anastomosing with the descending branch of left cholic artery. The lowest branches of the sigmoidal artery will be anastomosing with the superior rectal artery. This area, the area between the right 2/3 and left 1/3 of the transverse colon, is getting the weakest blood supply. These are the marginal arteries. They anastomose with each other at the margin of the colon. They are called as marginal artery of Drummond. About the venous drainage, veins follow the artery. Now let's look at about lymphatic drainage. There are 2 main lymphatic nodes, superior mesenteric node and the inferior mesenteric node. Generally, the lymph vessels accompany the artery. Jejunal lymph node, ileal lymph node of the cecum, lymph node of the appendix. They all drain into the superior mesenteric node. Lymph node of the colon will drain into superior mesenteric node and also into the inferior mesenteric node. Nerve innervation. Vagal nerve is the parasympathetic innervation of small intestine which causes peristaltic activity and intestinal secretion. T9 and T10 are responsible for the sympathetic innervation of small intestine which cause inhibition of peristalsis and pain. For the large intestine, vagal and pelvic splanchnic nerve are responsible for the parasympathetic innervation, as well as T10 to L2 will be responsible for the sympathetic innervation which causes pain in large intestine. Okay guys, these are all about the anatomical part of small intestine and large intestine. Now let's look about some clinical manifestations related to large intestine and small intestine. Well, we all know about the blood supply of the small intestine and large intestine. There are arterial arcades and straight arteries. The straight arteries are end arteries, but the arterial arcades are anastomosing with each other. Because of the straight arteries are end arteries, the occlusion of them infarcts the segment, but occlusion of the arcades is not harmful. Mucous membrane of the colon may herniate through vascular perforation. This is called diverticulosis. If this herniation gets inflamed, that is called diverticulitis. This is mostly commonly occur in descending colon and sigmoid colon. During a surgery in abdomen, we need to mobilize the intestinal organs to reach the organ which lie behind the intestine. Surgical mobilization of splenic flexure needs division of phrenicocholic ligament, as well as the surgical mobilization of descending colon is carried out by dividing the peritoneum along the white line of Tald. Surgical mobilization of sigmoid colon is carried out by dividing the parietal peritoneum of the floor of left iliac fossa and the lateral aspect of pelvic mesocolon. This is the most common site where congenital peritoneal adhesions occur. Now we just see about the hemicolectomies and colectomies. So the right hemicolectomy, the resection occurs here. Resection from terminal ileum to proximal transverse colon. Here we need to ligate the ileocolic and right colic vessels to prevent the blood loss. This is left hemicolectomy, resection from left end of transverse colon to the part of sigmoid colon. Here we need to ligate the left colic and upper sigmoidal vessels. This is transverse colectomy. Here we remove the right and left colic flexures, transverse colon, transverse mesocolon and great omentum. Here we need to ligate middle colic vessels. This is sigmoid colectomy. Here the removal of lower descending colon to rectum will be occur. Here we need to ligate lower left colic and sigmoidal vessels. Appendicular artery is an end artery, which means appendix is not getting blood from any other anastomosing branches. Appendicular artery may be thrombosed in appendicitis, which leads to ischemic necrosis and rupture of appendix. At this time, we need to remove the appendix through a surgery called as appendicectomy or appendectomy. For this surgery, incision should be performed at the McBurney's point. If we draw a straight line from umbilicus to the anterior superior iliac spine, this is the McBurney's point. This length should be 1/3 of the total length and This length should be 2/3 of the total length. And this is the McBurney's point. These are all about the clinical manifestations related to small and large intestine. Now let's see some MCQ and essay questions. Okay, first MCQ question about large intestine. Cecum is completely covered by peritoneum but has no mesentery. It's true. Cecum, ascending colon and descending colon are retroperitoneal and they don't have mesentery. But the transverse colon and sigmoid colon are intraperitoneal and they are covered with mesentery. Colonic plexures are the most fixed parts. Yes, we know that's true. The lymphatic supply related to the arterial supply. It is also true. We know the superior mesenteric node and the inferior mesenteric node. They all are accompanying arterial supply. In infants, the lumen of the appendix is narrow. That is false. We know that infants has wider appendix and the adult has narrow appendix. Elder people maybe have obliterated appendix. Attachment of apex of the sigmoid colon related to the sacroiliac joint. Sigmoid colon has an inverted V shape. The apex of the sigmoid colon is related to sacroiliac joint. So, the stem is true. Second question regarding ascending colon. Ascends superiorly into hepatic flexure. It's true. It ascends from the ileocolic valve to hepatic flexure. So, the stem is true. Second stem lies on the iliac fossa. Yes, true. It lies on the right iliac fossa and anterior layer of the lumbar fascia. Third stem supplied by right colic and ileocolic arteries. Yeah, we know the whole blood supply. It's true. Gives off vermiform appendix. No, it's false. Cecum will gives off the vermiform appendix, not ascending colon. May be relatively short. It is also true. We know the hepatic flexure is little bit lower than the splenic flexure due to the liver. So, ascending colon may be relatively short than the descending colon. Regarding colon, ascending colon lies on iliac fascia. It's true. Transverse colon is completely invested in peritoneum. Yes, true. Arterial supply to the colon is weakest between middle and right colic branches. It's false. Middle and left colic branches. Pain from descending colon is referred to periumbilical region. The referred pain. For the foregut, it referred to epigastric region. For the midgut, it referred to umbilical region. For the hindgut, it referred to pubic region or hypogastric region. Here, the question is descending colon. Descending colon is a hindgut origin. So, the pain will be referred to pubic region or hypogastric region. If the question is ascending colon is a midgut origin. So, the periumbilical region pain can be occur. So, this stem is false. Sigmoid colon usually lies in front of the rectum. It's true. Regarding jejunum and ileum. Ileum has thicker wall than jejunum. It's false. Jejunum has the thicker wall, feels like double layer, but ileum has a thin wall, feels like single layer. Arteries for jejunum form the narrow windows of the intestinal border of the mesentery. It's true. Jejunum form the narrow window while ileum form the wide window. Root of the mesentery cross the third part of the duodenum where superior mesenteric artery enter the two layer of the mesentery. It is also true. It is fully formed from the proximal loop. It is formed from the proximal loop, not fully, with distal loop also. So this term is false. Pain from intestine referred to umbilical region. We know midgut origin will refer to umbilical region. So the stem is true. True or false? Lymph from ileum drains to superior mesenteric nodes. It's true. Cecum, appendix, jejunum, ileum, colon all will drain to superior mesenteric node. Superior ileocecal recess lies in front of vascular fold of cecum. Not in front, lies behind the vascular fold of cecum. So the stem is false. Diverticulosis is most common in transverse colon than in sigmoid colon. We know it's false. Sigmoid colon is the most common site. About superior mesenteric artery. Doesn't supply the jejunum by its first branch. It's false. It may be supplied. Superior mesenteric artery supply the transverse colon by its last branch. The last branch of superior mesenteric artery is ileal branch. It will supply the ileal diverticulum if present. But the transverse colon is supplied by the middle colic artery. That's not the last branch. So the stem is false. Third stem, supply stomach and large intestine. We well know the superior mesenteric artery will supply the large intestine, but not the stomach. Stomach will be supplied by the celiac trunk. These all about the MCQ questions, and here I had put some essay questions which are asked in the exams in Jaffna University. You can try it. And that's the end of today's session. Thank you so much for listening, guys. Please do subscribe and keep supporting us. Bye.